one of the recommendations, number one, good communication is vital, and there's a good reason why this is the number one recommendation. So do not assume patient will pick up on suggestions or hints to see another practitioner. And you have to make it very clear to the patient that the doctor-patient relationship between both of you is breaking down, and you actually have to tell them that perhaps it might be better to see one of my colleagues. Perhaps someone else might have an alternative approach that may suit them better. You do have to make it very clear, otherwise the basis of your relationship is very shaky. So second recommendation is to document any patient non-compliance. And the thing with non-compliance is, again, good communication, and just thinking about, say, glaucoma eye drops. There may be quite a number of reasons why patients are non-compliant. It's not just because they're not listening to your advice. That there may be social issues, financial issues, particularly just trouble accessing the medication. But some people just don't understand the importance. And I've had patients. I had one recently that came back after 18 months, so poor follow-up, and took the drops for, say, the first month and just stopped. And it was very clearly documented in the chart that they were to come back after a month and have follow-up. But that they just totally disregarded that and came back 18 months later, and also to the detriment of their visual field. So there's some patients who just don't get it, and if they continue to have that type of behaviour, you have to make it very clear to them that it's not in their best interest to continue to take the medications in a non-compliant way. And perhaps it might be best if another clinician might be able to manage their condition better, especially if there's a communication difficulty. They say that memory is not a defensible basis for termination of relationship, and that's just making it very clear that you need to have good written notes. You can't just say, oh, well, I told the patient. You can't use that if you're, say, trying to defend your case in say, a legal sense. Certainly record all events of non-compliance as you become aware of them. And again, good documentation is the key.
I think you're absolutely right. I think we developed the glaucoma passport, and one of the things about the glaucoma passport is it's designed to empower the patient and give them all the necessary documentation they need on a long-term basis that they can refer back to. So, you can't have a patient say to you, well, nobody showed me how to put my drops in, or nobody told me I had to tell the DVLA, or nobody told me I had to take the drops for life or come back, because it's all within the document, their passport that they own. And I think this idea of giving patients more autonomy is extremely powerful. And as well as involving patients, it also protects the clinician, because it's a hard record that you have actually engaged, involved, and educated the patient.
Yeah, that's certainly what I like about the glaucoma passport. And you give it to the patient. You may even get them to sign that they've read all the content. It gives them something tangible to take with them. I had a patient recently. Their pressures in one eye were lower and compared to the other eye, and I suspected her eye drop technique was poor. Putting them in say her left eye. I watched her technique, and there were definite problems with the technique for the other eye, and that's where the glaucoma passport can be very useful to actually tell them exactly how to put their drops in properly. Number 3, do not delegate to staff. And as I was saying before, it's a very uncomfortable situation to be in, ending the doctor-patient relationship, and it's something that you don't have to do very often, hopefully. But yeah, when you do it, you have to do it well. And it's very easy to get someone else to do it. And, it happens in industry where people hire other people to come in and sack employees. So there's actually specialists who come in and terminate employment contracts. And I suppose it's a bit of a cop-out, really, in terms of the employer. But that sort of service doesn't and shouldn't exist in medical practice. And even though it is a very awkward situation to terminate the relationship, it really is best done by the doctor directly to the patient. I feel it's best done on a face-to-face basis. You don't want to do it, for instance, via an email or SMS. I think you have to talk to the patient on a face-to-face consultation, even though it is not pleasant, and then follow that up with actual documentation such as a letter.
Agree fully with that.
So this leads to the 4th recommendation: write a letter to the patient. And I think these days of electronic, it's still not good enough to write an email, because as we all know, emails can get lost, that they can actually, they don't always get acknowledged. You send someone an email, you're not quite sure whether it actually gets to the other end. Perhaps a letter is something a little bit more tangible. You can even potentially send such a letter by registered post, and that way that the patient has to sign acknowledgement that they've actually received it. And the letter's got to be quite specific, and we'll talk about what the letter should actually contain. But it's to inform the patient of the decision to end the relationship, so that has to be very clear, must be done in a non-accusatory manner, and you need to express concern for the patient well-being. So all those aspects we'll talk about in a moment. So number 5 recommendation is be careful about referral. And interestingly, this is where I differ from my medical indemnity bulletin, that they were saying you can refer to a medical colleague or refer to the yellow pages, and I didn't think that was quite appropriate. And I was thinking, well, what do I do if I need to refer a patient on? And I've put a few different options here, and I certainly like your input, Peter, as well. You can refer to a trusted colleague, and the issue there is that, say if you have a patient who is complex, maybe needs other subspecialty treatment, that makes it a lot easier to be able to refer to another colleague, either of your same subspecialty or a different subspecialty. I think the difficulty is when the patient, say, personality isn't suiting you, and may actually not suit your colleagues as well. But sometimes different patients do respond to different practitioners better, and it's often a very awkward conversation with your colleague if you've had difficulties, particularly if, say, there's been verbal disagreements with the patient you're seeing, and sending them on to your colleague, and that they may not always appreciate that referral. But it's a two-way process. they in turn may have patients they're finding difficult and that they need to send them back to me. And I find, over the years that's actually worked out a lot of the time. The patient realizes by the time they get handed on, that their options for their management are running out, and they often make an effort to be nicer to that second doctor because they know that they burnt their bridges from with previous doctor-patient relationships. So that can actually work. Yeah, certainly. I don't think it's good practice to hand patients on who are being difficult to your colleagues without notifying them. So always have that phone call and send them a copy of the referral letter. You do get some patients where you don't want to necessarily refer on to your colleagues, and that's when you can refer back to the original practitioner who sent you the patient, and this can be a difficult situation as well, but I put that in as an option. You can give the patient options for other specialists. So I remember having a patient it was actually wasn't the patient themselves, it was the patient's mother who came who was being difficult, and I didn't really want to refer them specifically to another colleague, so I actually gave them a list of all the subspecialty practitioners in the region that they possibly could be referred to. So it was more a generic referral rather than a specific referral to any one subspecialist. And then you've got the other option. Sometimes there's financial reasons why patients can't afford to keep seeing you, or commonly it's because they can't afford, say, the surgery. So that they need surgery and they can't afford to have that surgery done privately, so potentially you can refer them into the public hospital clinic where hopefully they will get the surgery they need. Any thoughts, Peter?
Yeah, no, I think that's very comprehensive. One thing that I always do is I do something called referral tracking, and that is whenever I refer somebody out of my care, whether it's because the patient is moving to another part of the country and they need to relocate with a surgeon elsewhere, or whatever reason, I always make sure that my referral containing all the clinical information hits the target. And by hits the target, I mean is received by the patient and is received by the referring clinician. And so if I make an important referral, particularly if the patient is a little bit, their disease is unstable, I'll make sure that the referral has hit the target by getting my secretary to ring the receiving clinician secretary 10 to 14 days after I've done the letter to make sure it's arrived on target, because the last thing you want is any unnecessary delay when you're transferring patients around.
I suppose that's easier when you are referring directly to another consultant that you trust. The trouble is when you've got a very difficult patient, they may be angry, maybe even violent or aggressive, and you don't really want to send them to another colleague, but they do need ongoing care. Like, what's your approach to that situation?
Yeah, I mean, if the relationship is broken down irretrievably and it's likely that the patient is going to be going back to their general practitioner, in the letter that discharges them from my care, depending on what their clinical problem is, I'll make 2 or 3 suggestions for clinicians within the region where they are who would be appropriate, and then I leave it for the referring general practitioner to make the next step of the referral onwards. But again, I make it very clear to the general practitioner that what time frame is acceptable for that process.
It's combining option 2 and 3.
Yeah.
It's awkward, isn't it? Like we don't like to be in this situation, but it's unavoidable if you are in practice for long enough.
Oh yeah, no matter how hard you work and how nice you are, there are going to be problems. It's inevitable. And although there are not many of them, they take up a lot of time and energy. I must say personally, when I discharge anyone from my care, if that occasional time when the relationship breaks down, I still like to close the loop, and I like to feel that I've referred them on somewhere and I know they're being safely looked after. I don't feel comfortable unless I know that they're being safely looked after. And that may be even in the presence of an acrimonious dispute with the patient. But actually, Graham, just if you don't mind me taking a quick aside, I just realised there's another cause which hasn't really appeared yet on any of your list or my list. And that is, what about the patient who repeatedly fails to settle their accounts?
Yes, certainly that is a major issue, and I suppose we have a few different strategies for that. Like quite a number of years ago, say for surgery particularly, where there's larger sums involved, we get them to prepay for their surgery, and before that we were mounting quite a lot of bad debts from patients who've had surgery and don't pay after the surgery. So we get patients to pay 1 week before surgery, and if they don't pay, their surgery doesn't go ahead, and that greatly has reduced our bad debt levels. Occasionally you have to compromise a bit, if there's known financial hardship, we sometimes allow patients to pay in installments, but that's pretty unusual. It would have to be exceptional circumstance for that. There's other companies too that can also provide financial assistance to patients, and they allow the patient to pay the company back for installments. It's always difficult if patients haven't paid their money, and occasionally we do need to resort to agencies like bad debt agencies, and they actually pursue the owing fees, and that they take a percentage out of that when they recover the fee. In terms of the consultation fees, most patients pay after they've seen me. So, we have what we call FPOST here, or electronic banking. We have credit card facility, and we allow patients to pay cash or check as well. So it gives them all the different payment options. So we don't have a lot of bad debt from actual consultation fees. Some of the problems arise from the quirkiness of our Australian Medicare system, in that when patients pay the balance of the consultation fee and they need to claim through Medicare part of the consultation fee, and Medicare somehow sends the check to the patient, and the patient has to send the check on to me, and often that can break down. We've had patients actually manage to bank a check from Medicare that was made out to me into their own account for whatever reason, and we've had to recover the money from that patient. I suppose getting back to your original question, what if the patient is refusing, not pay for your consultation? We usually nip it in the bud fairly early, in that the next time the patient presents for follow-up, the staff actually mention, you have an account owing. And if the patient still refuses after that second consultation to pay, we say, we can't continue to see you unless you've actually paid, and that's fairly cut and dry. If you couldn't go to a restaurant and have a meal and say, oh, I can't pay this time. When I come back next time, I'll pay. So, do you have a different approach?
No, I think that's very sensible, and I think what you've done there is cover all the options. And at the end of the day, as long as you know your patient's going to be safe and you've got a good system that works, I think that's fine.
Hmm. We've talked about this before, Peter. Like if you see a patient privately and for whatever reason they need to be referred into the public system, you don't generally see them further in the public system. You'd prefer if they get referred to another specialist in the public system?
No, I mean, if I've got a patient who's under my care privately, and let's say they've got problems with their insurance company or finance, which is getting increasingly prevalent in the UK, and they say, can I be transferred to the NHS? Then I'd always say, yes, I'm happy to do that. Now, it's quite a dynamic situation in the NHS in that many units are under quite a lot of pressure with new and review patient activity. So sometimes their general practitioner would refer them to a local unit, depending on how far away they've come from, or sometimes the general practitioner would refer them into my NHS unit. But all I make it very clear to the patient is that when you transfer from private to NHS, you have to take your place in the queue. And the fact that you've been a private patient in no way allows you to any special advantages over and above any other patient. So you'll be treated exactly the same way as every other NHS patient. And I think it's very important to make sure that patients understand that at the outset.
I've certainly had some patients say that they need urgent trabeculectomy, some sort of urgent surgery, and they're just financially not able to afford it. And I've had to refer them into the public system as a category 1, which is seen within the month. And there have been occasions that I've had to treat them publicly and get their surgery done, and I think that's in the patient's best interests, especially if it's an urgent condition. But yeah, it's a different case when it's a non-urgent referral.